Felicia.
I'm Brian Rose. Nice to meet you.
All right, nice to meet you. Felicia Eggleston.
Roger.
Roger. All right. Estefanos.
Yes.
All right. Felicia Eggleston. Terry Wilson. All right. Felicia Eggleston. Primary. Your name? Yep. You're primary. Welcome back. Because I know you've been here. Hope you all have had a good meeting. Call you up to get you acclimated with the podium for those who may have just make it their first time. So this is where you'll see your presentation. Everyone else will see your presentation here. You will guide your presentation using this box here, forward, back. Okay. So we ask that when you come up that you tell everyone who you are, disclose and invested relationship with the company, and then after you do your presentation, if there's a 5-minute speaker, we like to ask 5 minutes speaker, then we open it up to questions. I'm going to keep your time there. I have my time clock up there, remote control. When I call you up, hit the button, it's allows for 10 seconds to get here, and then you start to count down. We have 2 minutes left. I'll just whisper 2 minutes, and then that's the signal to wrap it up. And once you finish, just stand and approach the podium. Or if you just say at me, I'll say that you're on the side of the speaker. I'll be sitting right there next to you. So when we're done, we just walk. Yep, so you're here, you do your presentation, just glance back at me. I'll say no 5-minute or 5-minute speakers. If I say 5 minutes, just say that's pretty much it. Thank you all for coming. Appreciate having you.
What?
Disagree. Good morning, everyone. We're getting prepared to begin our meeting. If everyone could just come in and have a seat and quiet down. All right, good morning. Welcome to the annual HCPCS public meeting for drugs, biologicals, and radiopharmaceuticals. My name is Felicia Eggleston. I am the team leader for Part B drug team here at CMS. Just some general things that I'd like to discuss before we proceed with our meeting. Just want to let you know this meeting is being webcast via CMS. The CMS webcast is live and it begins when our meeting begins. By your attendance today, you are giving consent to the use and distribution of your name, likeliness, and voice during today's meeting. You are also giving consent to the use and distribution of any personally identifiable information, so we ask that you please do not disclose any personal health information on today. The webcast can be found in archives after the meeting on YouTube or the CMS Ustream website, and I believe that it is there permanently. So some housekeeping items. You all have come in. I believe everyone has passed the restroom. So if you leave out the doors to my left, you make a right-hand turn and proceed down the aisleway there, and then to your left you'll see some restrooms and some telephones. If you continue out to the main lobby from where you came in, and then you make that right turn by our elevators and just proceed down the stairs, that'll take you to our coffee stand and to the cafeteria. We have been asked to remind you that for security reasons, visitors may not enter any areas of the building other than the public areas, which are located on the lower and first floors of the central building, unless you are escorted by agency staff. If any of you will need assistance in arranging for taxi service today, please see the concierge at the front desk in the lobby. CMS is a non-smoking campus. There is a smoking area outside of the gates at both entrances. We'd like to ask right now that you would please put all cell phones and Blackberries on silent. I'd like to also ask that all speakers and anyone answering questions, please be sure to step up to a microphone so that everyone can hear you. This includes outside participants as well as agency staff. So for primary speakers, you'll stand where I stand and give your presentation. For all other speakers, we have a microphone right here in front of the stage. If you would just come up to that microphone, ask all your questions, we'll be happy to answer. So, with that being said, we'd like to also ask for everyone's cooperation and sticking to their speaking time. Primary speakers, you have up to 15 minutes. 5-minute speakers, you have up to 5 minutes. I'll be keeping your time today. We have a time clock over here. To my right, your left. I have a little remote control back here. I click the button, it starts your time. You can glance at it periodically and see your time. When you have 2 minutes left for primary speakers, I'll gently whisper behind you, 2 minutes. That's your cue to wrap it up. And then once your presentation is finished, either I'll stand and look at you if you've exceeded the 15 minutes, or you can just glance back at me. I'll tell you if there's a 5-minute speaker. If there's a 5-minute speaker, I'd like to ask that you would just sit in these chairs behind. I'll call the 5-minute speakers, and then we can open it up for questions. If you look at me and I say there aren't any 5-minute speakers, you can open it up for questions. Okay, please note that speakers cannot call on any other speakers or designate any unused time. Only I, your moderator, can call speakers to the podium. Time permitting, we will have a coffee break or lunch break today. Okay, so right now, I'd like to introduce Cindy Hake. She is the Deputy Director of CM's Division of DemiPost Policy and of the CMS National Level 2 HCPCS program. She will provide opening remarks and a brief description of the background and purpose of today's meeting. Cindy?
Good morning, everybody. So thank you for joining us. Today is the first day of a 3-day meeting for drugs, biologicals, and radiopharmaceuticals. And we have with us today members of CMS's HCPCS work group, representatives of manufacturers and suppliers of some of the items on today's agenda. government relations, regulatory and compliance, specialist personnel from various organizations, industry consultants, sometimes clinical specialists, every once in a while somebody from the press, and folks have more and more started coming to the meetings just to see how they go, that they may have an application that they're submitting next year, maybe a new work group member, just to see how our process is. So welcome everybody, we're very glad you're here. We know how busy you are. We appreciate your time and trouble and expense to travel to be here with us today. We're very grateful for your participation and your input. It really does mean a lot to us through this process. After we take comments through this venue on our preliminary decisions, we do reconvene, and every once in a while the decisions change, which is just confirming that this meeting really does works for us and works for our applicants. And so this public meeting forum originated for discussion of HCPCS code applications out of BIPA 2000 pertaining originally to durable medical equipment. Our first public meeting was in 2002. It was for DME only at that time, and there was one item on the agenda. I remember that day. And in 2005, we were pleased with the process and the results, and we thought that our decisions, we had better quality decisions taking input, and so we expanded the forum to take public input on all categories of HCPCS code applications and not just DME, which was as originally regulated. So before the public meeting, the HCPCS work group reviews all applications and formulates the preliminary decisions that we have published on our website and that you see in your agendas. The work group includes members who provide input based on their perspective of the national program operating needs of all government and non-government insurers. We have representatives for Medicare, Medicaid, the private insurance sector, VA, DOD. So everybody's at the table considering your requests. And we publish our preliminary decisions along with our rationale in advance of the meeting so that our customers, our applicants, the general public, any interested party can see what we're thinking and provide comments either in support of or to refute our preliminary decisions, either in person at this public meeting. We also accept written comments up until the end of the day on the day of the public meetings. After the public meetings, the work group reconvenes to reconsider every application before us, together with the input we've received, and we begin to formulate our final decisions. And as I mentioned earlier, sometimes our preliminary decisions are changed based on the input we hear via this process. We'll publish summaries of the public meetings sometime in August. Those summaries will look very much like your agendas, only they'll include an additional few bullet points that will be our attempt to capture the key points made by our speakers today. So those of you who are speaking today, please reinforce those key points that you have to support or refute our preliminary decisions, and we wish to adequately capture those in our summaries. Final decisions are released in the first week of November, hopefully. Hopefully we won't be furloughed. And so we'll be on target with the first week of November. I mean, it's happened before. We've had to delay our decisions. And we send out individual decision letters to our applicants, and in addition, a couple of years ago, we began publishing our final decisions in a couple of formats, in a spreadsheet format and in a text format on the website, and that's been pretty well received. So once again, this is your day. Thank you for coming. We look forward to your participation.
Okay. At this time, I will provide an overview of Medicare's Part B drug payment. A more detailed description of this payment for Part B drugs is attached to the end of your agenda. So, Medicare Part B pays for a limited number of prescription drugs. For the purpose of today's meeting, the terms drugs will refer to both drugs and biologicals. Currently covered Part B drugs generally fall into three categories. We have drugs furnished incident to a physician's office. We have drugs that are administered via a covered item of durable medical equipment. and we also have drugs that are covered by specific statutory provisions. Medicare Part B pays for some drugs using the cost or prospective payment methodology, typically under a prospective payment system, such as the outpatient prospective payment system. Drugs are not paid for separately. Instead, payment for drugs that are furnished during an encounter are bundled or packaged with other service furnished during the encounter. However, most Part B drugs are not paid on a cost or prospective payment basis and are paid separately. Historically, there have been 3 approaches that have been used to determine payment amounts for the latter part of these Part B drugs. So prior to January 1st, 2004, payment for majority of the Medicare Part B drugs was set at 95% of the average wholesale price. Effective 2004, the Medicare Prescription Drug Improvement and Modernization Act of 2003 reduced the payment rate for most covered Part B drugs from 95% of the AWP to 85% of the AWP. Effective 2005, the MMA required the implementation of a new pricing system based on a drug's average sales price. This approach is currently used to pay for majority of the Part B covered drugs. So, in accordance with Section 1847A of the Social Security Act, manufacturers submit sales data for their products to CMS each quarter. This data includes the manufacturer's average sales price for each drug, as well as the number of units of the drug sold to purchasers in the United States within a calendar quarter. The average sale price that manufacturers must report is net of discounts such as volume discounts, prompt pay discounts, cash discounts, free goods that are contingent on any purchase requirement, chargebacks, and rebates. The statute requires CMS to calculate a payment amount by determining the weighted average sales price for the drug products assigned to a specific HCPCS billing code, and then we add 6% to the weighted average amount. If an ASP is not available, for example, if a drug is new to the market, the wholesale acquisition cost, or WAC, may be used instead of the ASP. Very few sales are exempt from ASP reporting. Effective January 1st of this year, 2017, infusion drugs administered through covered DME are paid using the ASP methodology. So there are some exceptions to this ASP pricing methodology. Certain drugs are not paid using the ASP price. Payment for these drugs use methodologies such as the AWP, which were in place before the MMA authorized the ASP methodology. This list includes vaccines, blood and blood products, as well as radiopharmaceuticals. So, payment for Part B drugs is determined at the HCPCS billing code level. In order to facilitate appropriate payment, it may be necessary to create unique HCPCS Level 2 codes for certain products. CMS has continued to review how the statutory terms single-source drug, multiple source drug, and biological product are used in the context of payment under Section 1847A to identify the potential need to make any changes to our assignment of a national drug code to billing codes for any payment purpose. Also, in accordance with revisions to Section 1847A of the Social Security Act made by the Affordable Health Care Act, CMS has begun to incorporate biosimilars that are approved under the abbreviated biological approval pathway into the ASP payment methodology. So that we can implement coding and pricing changes promptly, CMS has used and will continue to use its internal process when appropriate for modifying and updating the HCPCS code set. Please be aware that internally generated code requests are not part of the HCPCS public meeting process. ASP payment determinations are made by the Division of Ambulatory Services and the Hospital and Ambulatory Policy Group. DAS maintains an email box for inquiries related to the ASP payment methodology. If you have any questions, you can submit them to this email address. It is SEC, short for section, 303, ASP, as in average sales price, data at cms.hhs.gov. Okay, that concludes our little summary. So, at this time, I'd like to introduce some CMS HCPCS staff. Many of you may have had the opportunity to speak with them on one occasion or another to get your materials in for this meeting. When I introduce them, I would like to ask that they would please stand so that you can see them and associate a name with a face. Judy Wallace. Nathan Hellman. And Kimberly Combs Miller. These are your CMS National HCPCS Workgroup meeting coordinators. They worked very hard to put all of the details together so that you can have this opportunity for input on today. We are pleased that these meetings are now open to a wider audience by instituting live stream for the HCPCS public meetings. So I'd also like to introduce our medical advisor to the CMS HCPCS Workgroup, Dr. Preeta Chidambrian. At this time, we'd like to thank Charles Hirsch and our guys back here in the booth for handling all of our audio-visual needs on today. Now I'll describe how this meeting will proceed. So everyone should have received the agenda prior to coming into the meeting. If not, there are some still available on the table. For each item on today's agenda, you will find a written summary of the application and CMS's preliminary coding decision within the agenda. The meeting will proceed one agenda item at a time until we have completed the agenda. We will hear a presentation from the registered primary speaker, if there is one, as well as any 5-minute speakers, if there are any. We'd like to ask that every speaker, when they come up, that they would state who you represent, state your relationship to the applicant and to the manufacturer, declare in your oral presentation and in your written summary whether or not you have any financial involvement with the manufacturers or competitors of any items or services being discussed. This includes any payment, salary, or benefit provided to the speaker by the manufacturer. State whether you agree or disagree with the preliminary decision, and when you summarize your comments, state your rationale for agreement or disagreement. After we've heard from all registered speakers, we will invite discussion and questions specifically related to that item. With that being said, I will now introduce agenda item number 1. It is application number 17.12, a request to establish a new level 2 HCPCS code to identify Ocrevus. There is no primary speaker and no 5-minute speakers for this item. Are there any questions or comments? Agenda item number 2, application number 17.2. Request to establish a new level 2 HCPCS code to identify Stelara for intravenous infusion, and request to revise existing HCPCS code J3357 so that we can distinguish between the IV and sub-Q versions of Stelara. Primary speaker is Mr. Michael Ziskin.
Good morning. My name is Michael Ziskind. I work with Johnson & Johnson. I'm an employee of J&J, and my title is Director for Health Policy and Strategy. This may be the shortest presentation of the day. In brief, we concur with CMS's recommendation. We think that the temporary Q code transitioning to permanent code for a single milligram of ustekinumab for intravenous administration or injection effective 7/1 transitioning to 12/31 is appropriate. We had originally asked for 130 milligrams to represent the convenience of billing in single unit vials. The drug is dosed in 2, 3, or 4 whole units. But from our perspective, either one is workable. We do understand that a specialty society will be likely asking for it to be coded in whole units of 130 milligrams for the convenience of their membership, but either is workable in our view. So that said, it was necessary to issue this code because this drug has a very large loading dose that's unusual in its pattern of administration, has only one specific use, and this code will permit more accurate claims processing, will prevent overpayment and prevent accidental claims errors. So I also want to extend my thanks to the CMS staff that have worked extensively with us over the last year on this issue with the meetings they held with us, and appreciate their high level of responsiveness. Those are our comments. We concur. Okay. Any questions? No?
All right, thank you.
Agenda item number 3, application 17.25, request to revise the dose descriptor of existing HCPCS code A9587. Primary speaker is Mr. Roger Estefanos.
Good morning, everyone. My name is Roger Estefanos. I am an employee of Advanced Accelerated Applications. For short, I'll use the acronym AAA. My title is the Head of Price and Market Access for North America. I thank you for the opportunity to come here and present to you and hopefully address any questions. Netspot gallium-68 dotatate was approved by the FDA in June 2016 of last year. It was approved as a kit for the preparation of gallium-68 dotatate injection, and that is for intravenous use. The picture you have here is the product as approved by the FDA is a kit that includes 2 vials and a cartridge that is used in a reconstitution process. Netspot is indicated for use with PET imaging for localization of somatostatin receptor positive neuroendocrine tumors in adult and pediatric patients. Neuroendocrine tumors, or carcinoid cancer, or also called for short NETs, is a rare disease. The prevalence of the disease is 48 in every 100,000, and incidence is about 7 in every 100,000. 80% of NET overexpress somatostatin receptor, which is the technology leverage in both treatment and imaging in the disease, which is also used for in Netspot dose. Netspot has been studied for many years in the US and Europe and demonstrated change in patient management in about 60 to 70% of patients. In a study by UCLA, 41% of patients scheduled to undergo surgery were switched to treatment without surgery after imaging with Netspot scan. The image on the right is a side-by-side comparison. On your left, this is the Netspot gallium scan. The right is the old standard of care. So you see here, that's a very informative scan for surgeons and as well as physicians. AAA submitted the application requesting a change in a descriptor of the code A9587 from per 0.1 millicurie to per study dose up to 5.4 millicurie. The preliminary decision was to keep the descriptor unchanged. We respectfully disagree with the preliminary recommendation for the following reasons. First, the FDA approved the product as a kit, which means one dose can be reconstituted from one kit. So one kit equal one dose. Can't be more than one dose reconstituted from the kit. Also due to the short half-life of the product, which is 68 minutes, from the moment it's reconstituted, the institution or the facility that administered the product is very hard for them to figure out exactly what was delivered versus what was administered. So trying to figure that out, it's adding burden to the facility as well. Also, the other radiopharmaceuticals used with PET imaging are all described per study dose. And then finally, based on use since the code was taking effect in January 2017, we observed some administrative burden, which I'll touch on a little bit in my presentation. So as I mentioned, the FDA approved the product as a kit. So one dose equal one kit. Since the product launch, 98% of the doses that were prescribed were within the 10% allowed within our label. So the max dose is 5.4. There is a plus or minus 10%, and 98% of the doses prescribed were at or greater than 4.8 millicurie. So I'm going to go through the process at a very high level here. So on the left, the picture, this is the product as approved by the FDA. The process of reconstitution involves using a gallium generator where the gallium-68 is eluted out of the generator, using the 2 vials and a cartridge that comes with the kit. I'm not going to go into the technical details, but there are a couple of comments to make here. Because of the short half-life of the product, the radiopharmacy where the product is prepared has to be within 60 minutes of where the facility is, where the product will be administered. So the facility, the PET imaging facility, needs to be within 60 minutes drive from where the product is reconstituted. And that also manifests itself in the QC process. The product leaves the radiopharmacy without QC testing, quality control testing. That test happens as the dose in transit to the facility. If in any situation where the dose fails the QC, the driver is called to turn around back to the radiopharmacy, and then the patient will get rescheduled to another day where another dose is prepared for the patient. So unlike most pharmaceutical drugs, Netspot decays and also radiopharmaceuticals as well. So again, I'm not a physicist, so I'm not going to bore you with the details of this chart, but this is essentially a decay curve for any radiopharmaceutical product. There are certain considerations that need to be taken into account when we talk about radiopharmaceuticals. One is how far the facility is from where the product is prepared. So the drive time between the facility and the radiopharmacy, the patient availability. So is the patient ready at the facility when the dose arrives? Are there any unnecessary prep steps or prep time that's required for the patient when the patient is there? And then finally, imaging techniques. Imaging techniques and the specs of the machine, the PET imaging machine, also impacts of how long the patient sits in the machine itself, which also it plays a factor as well. So this is a decay curve for our product, Netspot. And as you see here, this is the 5.4 max dose, 5.4 millicurie. And within the allowed plus or minus in our FDA label 10%, that would get us to somewhere between 4.9 to 6 millicurie. Also, imaging can technically happen plus or minus 10% based on the scheduling and availability. So that also adds uncertainty what the exact dose has been administered. It's all within spec of the product and a PET imaging machine as well. So realistically, for a max dose of 5.4, a dose that could be administered is somewhere between 4.2 to 6 to 7 millicurie, and that would still be imaged properly, and the patient would be successfully imaged. So I'm going to go through a quick scenario where we have the same patient with 2 possible scenarios here. So as I mentioned, some of the key factors that impact a radiopharmaceutical before the injection, that includes the prescribed dose versus what's delivered. At the time of injection, patient preparation, as I mentioned, also what is in the dose that's been injected. And then after injection, once the patient is injected with the dose, the imaging time plays a factor, and the PET machine, the PET imaging machine specification. So this is the same patient. If it's scenario 1, the doctor prescribed 5.4 millicurie, the max dose. But that day, there was a little bit of traffic, so instead of 5.4, 5.0 was delivered. The patient was ready, PET machine was ready, everything was running on schedule at the facility. Total prep time was just 10 minutes, which is on the low end for a facility. 4.5 millicurie was actually injected, and the imaging time was about 30 to 40 minutes, which is, again, very typical of a PET imaging machine. Same patient, scenario 2, the same 5.4 millicurie was prescribed by the physician. However, traffic was light that day, so 6.0 millicurie was delivered. The patient was running late, and the PET facility was backed up, and the imaging machine won't be ready for another 45 to 60 minutes. In this case, 3.3 millicurie was injected. If you increase the imaging time, you get the same results. The PET machines right now, they're impeccable in their technology, so if you keep the patient a little longer, that would be as well. In this case, both scenarios, same patient with different dose administered, leads to successful imaging. However, while it's the same, the cost of the facility is the same, the reimbursement is different in this case. So some of the issues that we've observed since the product has taken effect in January, when invoicing is required, when an invoice is required by the MACs, some institutions have received resistance for payment because the unit on the invoice does not match the unit that's billed. On the invoice is per dose or per kit, and what they bill is per 1 millicurie, so there is a little bit of discrepancy there. Also, within the institution themselves, when they get onboarded and ready to order the product, they've encountered the same issue loading their product in their own system in the charge master, because what gets loaded is what they order from the manufacturer, but what they bill is different. So we've seen some discrepancies, some challenges in that area. Also, we've seen, because they're used to other radiopharmaceuticals in the diagnostic space billed at per study dose, they've entered one by mistake thinking that it's per study dose, and when in reality it's actually they have to enter 54 for max dose or whatever it is the unit dose, the units for what's injected. And then finally, GW modifier, we understand it's not allowed for billing decayed radiopharmaceuticals, so the hospital has no way of recouping this cost if there is a delay, as the scenario that I went through. So in summary, AAA urges the work group to reconsider the preliminary decision and respectfully request the descriptor to be changed to per study dose up to 5.4. We think that the change will improve the code by eliminating any confusion regarding ordered versus received versus administered dose. Also aligning the reimbursement to FDA approved, again, at 1 kit equal 1 study dose. Aligning Netspot to other radiopharmaceutical to eliminate any confusion. And then finally, hopefully would eliminate any administrative burden. Thank you, and I'll take any questions.
At this time, I'd like to call Sue Bunning.
Morning, I'm Sue Bunning. I'm with the Medical Imaging and Technology Alliance, or MITA. I'm pleased to comment today on the HCPCS preliminary decision for item number 3. MITA is a trade association that represents medical imaging and radiopharmaceutical manufacturers. MITA respectfully disagrees with the HCPCS work group preliminary decision on item number 3. With regard to existing code A9587, MITA believes the current 0.1 millicurie descriptor for diagnostic gallium-68 dotatate does not appropriately describe Netspot. MITA supports the applicant's request to instead have it read gallium GA-68 dotatate diagnostic per study dose. As you have heard from the speaker from AAA, the Netspot kit, FDA approved, allows for only one dose to be reconstituted. A short half-life of 68 minutes, coupled with possible logistical delays, such as delivery delays or patient scheduling changes, can lead to greater decay and a different administered dose than the prescribed dose, and this could lead to confusion. Might also supports the medical community's comments that the current descriptor could lead to unnecessary administrative burdens and errors in billing and payment. We believe Netspot's descriptor should be changed to a per-study dose. Netspot should be treated like all other PET radiopharmaceuticals, such as Amyvid, Vizamyl, Neuraceq, C11 choline, FDG, sodium fluoride, Cardiogen, and N13 ammonia. Thank you for allowing me to comment today.
Denise Merlino.
Good morning, Denise Merlino from the Society of Nuclear Medicine and Molecular Imaging. You have hopefully received a copy of a letter that was sent last night from the Society of Nuclear Medicine. Those are our official comments. Additionally, Dr. Barry Siegel sent a letter, and I'm going to refer to both of those, so if you don't have them right now, definitely after the meeting if you want to take a look, because I'm going to refer to those particular comments. And I also want to comment with regard to some of the things that the presenter said. Number one, the society believes that per study dose is the appropriate dose. Based on what the presenter just showed us about the actual number of up to millicuries, the society might reconsider their suggestion and consider up to 7 millicuries, because what we don't want to happen is if you truly can administer that higher end, then we would want the up to amount to go to whatever that upper 10% limit would be. So that's number one. The other thing that I didn't hear the presenter speak to that our members tell us is that they only pay one particular cost. So they negotiate with the pharmaceutical company, and they're paying, I'll give you an example, $3,000. So it doesn't matter whether they received the 3 millicuries or the 6 millicuries, they're paying $3,000. So I think that's an important part to this whole scenario. We've had to work with some of the providers because they have to set up a very complicated charge master. And that's what Dr. Barry Siegel sent to you, is that they have the same charge and they have to change the per unit on their charge master in order to change the price for each unit based on what's actually delivered to the patient. It becomes extremely burdensome. I've seen some charge masters have 12 lines just to accommodate this one code description. So we do believe that per study dose for the PET tracers is the right way to differentiate, because these are very short half-lives and we need to be able to work with them in a range. The other point that I wanted to make, which the presenter also made, is that all the other PET tracers have a precedent that they are described as per study dose. Additionally, this panel last year, we presented to you on C11 choline, again another PET tracer, same situation, and this panel agreed and put a final recommendation of per study dose. So this particular product is actually very similar to the C11 choline. I think this is, last item that I want to reference is the JW modifier. So we certainly have worked with many of our providers with regard to how to report the waste and spoilage using the JW modifier. We have one MAC that has outright said that you cannot use the JW modifier on the radiopharmaceuticals. There have been sort of spotty recommendations. We are trying to work with that particular MAC, because if this coding change stands, then we are going to need to have a way in which to record that decay or that waste. So bottom line is that the Society of Nuclear Medicine does recommend to be consistent with the PET radiopharmaceuticals at per study dose. and we will send you a revised letter that says the up to amount would be per 7.0 millicuries. Thank you, and I'll take any questions.
Denise, did you say that the price per unit changes based on how much is administered?
So the price per unit does not change to the provider, but what the facilities are doing is in their charge master, they're trying to reflect the fact that their end price is a set figure. So what they do on their charge master is they change the unit they change the cost per unit of what they're going to bill out so that the number of units matches it. This is in the hospital setting in order to report to the hospital their true costs. So it's kind of playing with that charge master. And if you look at Dr. Siegel's, I think you'll get the gist of what they do. But the bottom line is that in the hospital setting, if they were to bill out 30 units, so say they get that 3 millicurie dose, they're going to be underpaid because the HOPS is going to only pay them whatever that amount is. So unless they use the JW modifier, they're still not going to be able to get paid for that differentiation. And that's why we believe that it's important to go back to the per study dose.
Do you have any idea what percentage of the time this is a hospital-based procedure?
Probably a higher percentage. I would say 75% of the time it's a hospital.
It's 70 to 80% of the time it's a hospital outpatient.
Okay, so there's not a lot of driving going on in those instances, all the dose decays?
These are done in limited studies because it has to be close to the cyclotron. I mean, that's just, it's key that sometimes they're on site, sometimes they're off site. So if you're outside, as our presenter Roger told us, that if you're outside of that 60-minute window, then you're usually not contracted in order to provide these services.
And if I can add
Yes.
one thing here, the hospitals don't generally have the gallium generator
Right.
on site, so this is where a local radiopharmacy comes in play. So it's not a matter of walking them up from where the pharmacy is. It's actually a matter of actual driving from the local radiopharmacy. Most of hospital outpatients do not have generators on site.
Yeah.
And for Medicare, this is still, is this still covered only under coverage with evidence development studies?
No. So this is
that approved
local
now?
contractor discretion. And it is being covered. There are several policies out there where they are covering and paying for this.
From the Medicare contractors?
Mm-hmm. Yes. I think Noridian has a policy that you could Google and it would pop up. That's it. Thank you.
Great. Thank you.
Agenda item number 4, request to application number 17.61, request to revise existing HCPCS code A9588. Primary speaker is Ms. Terry Wilson.
Thank you. Good morning. My name is Terry Wilson. I'm the Director of Patient Access and Healthcare Policy for Blue Earth Diagnostics. I am a full-time employee of Blue Earth Diagnostics. We appreciate the opportunity to present today on fluciclovine and the preliminary decision. Our indication for Axumin, which is fluciclovine F18 injection, is it's indicated for PET imaging in men with biochemically recurrent prostate cancer based on elevated PSA levels following prior treatment. This is our important safety information, and you can visit our full prescribing information at www.axumin.com. Our current descriptor for fluciclovine is A9588, which is F18 diagnostic, 1 millicurie. And the requested descriptor was A9588 fluciclovine F18 diagnostic per study dose. The request was, the preliminary decision was not to make the change to the per study dose, but really believed that this descriptor would improve the code for several reasons. So what we'll talk about today, overview, it's a diagnostic radiopharmaceutical, which is similar to what you just heard on the previous presentation. The current descriptor is not consistent with the clinical utilization of the product. Other PET diagnostic radiopharmaceuticals are all described as per study dose, which you heard from the previous presenter. And there has been confusion within both the MACs, the imaging centers, and the hospitals with billing this product. So as a diagnostic radiopharmaceutical, we use fluorine-18, which is a different radioactive element, and our half-life is 110 minutes. So half of our dose is gone every 110 minutes. The radioactive doses are typically ordered for a certain level of activity at the time of calibration. This dose is usually in millicuries, but the calibration time is the intended patient injection time. When the fluciclovine is developed, we have a 30 milliliter vial. It's a multi-dose vial at the end of manufacture. This stays in a hot cell at the radiopharmacy, and it's protected in a leaded hot cell so that there's not too much radioactivity in the pharmacy. The radiopharmacist will then pull up the doses. Because we're decaying by half every 110 minutes. We're losing 10% of our dose every 22 to 25 minutes. They're pulling doses for a future time. So they're accounting for the decay in the dose, as well as the future time when the patient will be injected. We will distribute up to 3 hours outside of the radiopharmacies. And due to the nature of the radioactive decay, most of the contracts that our distributors have in the radiopharmaceutical industry do allow for a variation above or below, because it's really hard to predict exactly what the dose is going to be at a future time when you're including the radioactive decay. So just looking at the clinical practice, Axumin is always ordered in a 10 millicurie unit dose. It's not weight-based. Some radiopharmaceuticals might be weight-based, but ours is not. So every single patient who receives a dose of Axumin will receive 10 millicuries a dose at the calibration time. The price for a 10 millicurie dose is the same for every single dose, and our reporting to the Red Book, so our pricing compendia is also as a unit dose, a 10 millicurie unit dose. When a patient comes in for an Axumin scan, we do not have a delay between the injection and imaging, so the patient must be put on the table. The injection occurs, and then 3 to 5 minutes later, the patient's scan begins. So the patient has to be positioned on the scanner before we can do the injection. Delays can occur if the patient's stuck in traffic, late, if the scanner was backed up from an earlier patient issue in the morning. So there are potential for delays in these situations. And due to the half-life, we are losing a millicurie between every 22 and 25 minutes. So a patient could be injected with less than 10 millicuries if they are delayed. We have transitional pass-through right now in the hospital setting, and so that is creating a challenge for the hospitals in billing. We already had some speakers mention the JW modifier and some of the confusion surrounding that. I won't read to you all of the PET radiopharmaceuticals again, since you've already seen this slide before, but all of the other doses that are used for diagnostic PET imaging are described as per study dose. So what this has created is a lot of confusion at the imaging centers as well as the MACs. Several of the MACs are requiring an invoice for the non-hospital claims. One MAC set an incorrect allowable, which could have resulted in a 10x payment for this product. they changed it to invoice because of the confusion looking at the pricing compendia, what was on the invoice, and then the code descriptor. But importantly, at the hospitals and imaging centers, it's become a challenge for them. There are, in the United States, about 2,000 PET imaging facilities. We are a new product, and we have about, as of the end of the first quarter of this year, about 150 PET imaging centers who are using the product. I have personally spoken with about 15 of those PET imaging centers who have contacted me because they have billed for 1 unit, and they don't understand the payment is 1 unit, and they should have billed for 10 units or the appropriate number of units based on the descriptor. This has resulted in underpayments and probably, looking at my dose charts, probably about 100 resubmissions because the dose descriptor, the units were incorrect. So we believe that the per study dose would improve the code. We respectfully request that CMS reconsider the code descriptor. We have mentioned we would like to be consistent with all the other diagnostic PET radiopharmaceuticals, reduce some of the confusion among the providers, reduce any of the claims resubmissions that we're having, and ensuring that hospitals are reimbursed appropriately.
I'd like to call Sue Bunning.
Hi, Sue Bunning with MIDA. Thank you again for allowing me to comment this morning on the HCPCS preliminary decision with regard to item number 4. As I mentioned, MIDA is a trade association that represents the medical imaging and radiopharmaceutical manufacturers. MIDA respectfully disagrees with the work group's preliminary decision on item number 4. With regard to existing code A9588, MIDA believes the current descriptor, which reads fluciclovine F18 diagnostic 1 millicurie, does not appropriately describe Axumin. Axumin is supplied as a 10 millicurie patient-ready dose at the time of calibration, and the price for this doesn't change whether it's for 5 or 10 millicuries. As with item 3, MIDA supports the applicant's request for a per study dose due to the very short half-life of 110 minutes and the logistical challenges of getting the exact doses to the site at the exact time of scheduled calibration. MIDA appreciates the comments also from SNMMI and supports their belief that the current descriptor creates confusion with coding and billing issues. Again, as with item number 3, we believe that Axumin should be treated the same as all other PET radiopharmaceuticals. Again, thank you for allowing me to be here this morning and to comment.
Denise Merlino.
Denise Merlino, Society of Nuclear Medicine and Molecular Imaging. I guess you have a letter with regard to this particular item as well. All of the things that I said on the last tab would come forward, but I think the one thing that I would like to bring to everybody's attention is that this open meeting is extremely helpful even for me as I listen to the individuals present forward, because while I understand how radiopharmaceuticals work very well, I can understand how it can be very confusing to understand the translation. And Sue Bunning mentioned the confusion around the coding. Now, we certainly can educate our members, and we do educate our members, but the important component here is that there is a range for these that we are given. And the range has to do with the fact that it decays and disintegrates in a very short period of time, and that's what these PET tracers are. And that's why we believe that the 10% above and the 10% below what we order and intend to give the patient is best described as per study dose. And so that was something that we talked about many years ago when we were creating the structure, is that certain tracers are purchased in that per study dose. PET tracers are that. They do only pay a set price. So whether or not, again, they purchase they will, for instance, with this product, they will order 10 millicuries, but they could actually administer 4 millicuries, or they could administer 11 millicuries. All of that would be well within the FDA prescribed dose, but yet all of that would still cost the facility $3,000. We've heard that there's no way for the hospitals to recoup the cost when we have the decay, but I also want to say that the Society of Nuclear Medicine is aware that we also don't want to put any incentives for somebody to game the system on the other side. So I think it's important for CMS to consider that one of the other reasons, not only to recoup the cost when you have the decay, but we don't want anyone playing with that and ordering a higher dose in order to get paid more as well. So I think there's both sides that have to be considered, and that is why originally we made that recommendation for these very short half-life radiopharmaceuticals to be per study dose. So those are my comments. Thank you.
Any questions?
So I have a question, if I may, about the 11 MCI dose for this product and the proposed 7 MCI, up to 7 MCI descriptor. And Denise, you mentioned that these are well within the FDA prescribed dose. The FDA doesn't prescribe doses. However, they do look at clinical studies. And the FDA clearance document for the Netspot is 5.4 MCI, and it's 10 MCI for the Axumin. So I don't know how you could suggest a higher dose than the FDA has looked at clinical information for and cleared.
We don't suggest a higher dose. We suggest always a 10 millicurie dose, but due to the nature of the radioactive decay, if the dose is arriving 30 minutes before calibration time, if the patient arrives early as well and the scanner is available, then it's possible that a hospital could inject 11 millicuries. So we always prescribe 10 millicuries. By the same token, if there is a delay, then the patient could be injected with less than 10 millicuries.
So there's the prescribed dose, which is what we order. And then there's the actual administered dose of what is given to the patient. And within all the Society of Nuclear Medicine's guidelines, and as well as, I believe, in the package insert, it says 10% above and below what that figure is. So again, I know it's confusing, but there are providers, who they're running on time and they can't stop, and I can't say they're not going to in their department, even if it's, for 0.5 millicuries, they will still administer that dose that's slightly above. So I understand it sounds confusing, but that's the fact of how providers are actually using the products.
So when 7 millicuries of Netspot is administered, or 11 millicuries of Axumin, how's that billed? What's billed? The 11, the 7 and 11?
In today's world, they would be billing per the units that we have today, which we believe is incorrect.
Okay, so they would be billing 7 or
they'd
the
be billing.
multiples
I mean,
to get to the 7 and to get to the 11. Is that accurate?
Yes.
Okay. So in tomorrow's world, if we were to make a dose descriptor of up to 5.4,
they'd bill 1.
And they'd only bill 1, are you sure? Because if they give 7 millicuries and it's more than 5.4 and it's up to, would there be an opportunity to bill 2 units and then overbill?
No, and that's what we're trying to avoid. That's why we want to make sure we have the 10% above and below.
Interesting.
With the previous codes, may I go back to a slide? The previous codes, I will use the example of sodium fluoride because I also submitted that application, I think it was in 2007. Sodium fluoride, a patient would not receive 30 millicuries of sodium fluoride. So the descriptor is actually, the up to amount is more than a patient would be injected with. So a typical dose for a sodium fluoride is between 10 and 20 millicuries. So you wouldn't see a 30 millicurie dose injected. So having that upper limit be at a higher millicurie level would avoid the potential of people trying to bill for 2 units.
Denise, I have a question for you.
Yes.
Both companies have spoken about all of the other PET products are currently using the
Per study dose,
per study
yes.
dose. What about other radiopharmaceuticals other than the PET products?
We have other tracers that are also described per study dose. And again, Cestamib is one of those, A9500, and that is for the same reason, in that when we give those particular study doses, we're going to give them in a range of 7 to 15 millicuries, and we do not, and the CPT code description says multiple studies, and a study is defined as rest or stress, so you could give 2 study doses, and it has an up to amount. So that's how we account for folks not abusing that particular radiopharmaceutical and buying something and splitting it and doing something bad out there. So there are other tracers besides PET tracers that have that per study dose. And many years ago, I presented to this panel about the complexities of those. And so when a product is purchased in this range, we want a per study dose description. When a product is purchased per millicurie, we want a per millicurie description. And there are many instances where we have gallium 67 is a per millicurie. Thallium 201 is a per millicurie, because that's how we purchase those particular items, and they have longer half-lives, and we can be more accurate with, and it marries to the how we're purchasing it. These particular products with a very short half-life really lend themselves to requiring that per study dose description, because we are working within a range. And we could provide some of the society guidelines that would show the different products and show you that, yes, we strive for what that FDA labeled indication is. That's what we order. But based on patient schedules, delays, patients showing up, patients' anxiety, we may be running ahead of schedule. We're not going to stop and wait for that product to decay. We're going to give the 5.8 millicuries or the 6 millicuries. That's what we're going to do. And you're not going to go squirt it out. It's not good practice. So these are just how you have to practice in the nuclear medicine field.
So I have a question now, because the numbers don't add up for me, based on what you just said, using your sodium fluoride example. So if nobody ever gets 30 millicuries, is that what you ship it from the lab? Is that the value you ship it from the lab, assuming that it will decay and get down into that 10 to 20 range by the time it gets administered to the patient?
So at the radiopharmacy, they are pulling the doses for the calibration time. So if the dose is next door, so the dose is 10 to 20 millicuries.
I understand about radio decay, okay? And I understand that if you know I'm going to calibrate it in 15 minutes and I want to calibrate it to such and such a value, then I need to add this much X in, so that in that time frame I get the number I need. I understand all of that. What I'm focusing on is what you said. The number in the code descriptor, up to 30 millicuries. Nobody would ever give that amount.
Oh, that's not true.
Because this is what you said.
Correct.
Because
that's what
the
she
dose
said.
is between 10 and 20. So that creates a problem for me. If that statement is true, which you said it, so I accept it as true, except she says it's not true, okay.
She does something different.
The problem is then what do we do with this 5.4 and the 10, which really should be 7 and 11? You see, so I'm having trouble with your numbers here about what's the maximum and how to prevent this overbilling, and all of this radio decay stuff really doesn't matter, because all that matters is what's the maximum that's going to come out of the lab, so that you don't end up being able to say I gave more than the unit of service, and therefore I get to bill 2 units of service. So reconcile that for me.
So if I can speak to that. So the sodium fluoride is a patient-weighted dose. So I don't want to put words in Terry's mouth, but I think what she was saying was the typical dose is around that. It's not, so what we do for the Society of Nuclear Medicine is, first of all, we have guidelines. And in the guidelines for each of the different procedures, it will say what the typical is, but it also will give the plus or minus. We also had, when we came to you all many years ago to present the whole structure, we brought the textbooks of here's the typical, here's the min, and here's the max. And so that 60 came from the max out of the textbook of what we're trained in nuclear medicine, which we could provide to you again if that would be helpful.
So again, I've got 20 years at a Mac. Okay, so this is where I'm coming from.
Mm-hmm.
The HCPCS code descriptor, 1 unit of service equals X, whatever number X is. If you give more than X, if there's a legitimate scenario where you can give more than X,
Correct.
then you're entitled to bill for the more that you gave. Now, you're telling me that you don't want them to do that.
Correct.
So what and I understand your plus and minuses and all of that stuff, but from a coding and a MAC point of view, if you do plus 10%, and you actually give that plus 10%, and your X is the number in the middle, you've just created a scenario that justifiably, from a Medicare correct payment rules situation, allows them to bill for 2 units of service. So how does your textbook scenario and everything that you just said prevent the double billing that you say you're trying to prevent?
Well, first of all, the Society of Nuclear Medicine has always advocated that we think the up to amount has been confusing for some of our members to deal with. And it's not our preferred. Our preferred is just per study dose and stop there. And let the guidelines guide what the up to amount is. We do have guidance on our website, which we could share with you. It's a coding and reimbursement Q&A. And because we want to avoid the instance where somebody can go over it. And so we talk about the per study dose as a per study dose that is, and the up to amount is an intended guidance. And that it is not intended that you go over, and if you do go over by 0.1, that was not the intent of the code, and we tell folks that they should not be coding and billing for it in those, if they happen to go over it in that particular instance, because we view the per study dose as the key component of these particular codes. So, you know, it's a struggle for us because we want to make the up to amount high enough that people can't abuse it, but I understand that it's hard to get to that with the math because you may have, if it's a weight-based patient, you may have to go to that, but we don't want people abusing it. So hopefully that explains. And we're on your page as well because we don't want to see abuse, but with the current description that we have in play, there could be some abuse. And there could be hospitals that are underpaid. It goes on both sides.
So, Denise, now the document that you sent me last night or this morning is from Merlino Consulting. So are you here as a representative of the Society of Nuclear Medicine?
I am.
I thought you quit that gig.
No.
But, okay. All right.
And I've worked for them for many, many years, and I'm a member of them as well.
Okay, that's not where we received your comments from. Okay.
But
I was just wondering if you,
that's
if
just
you had
my
a
email
relationship
address.
with the applicants as a consultant
No.
in any regard.
No,
Okay.
I am and always have been, and my contract forbids me to work with other industry nuclear medicine folks. So yes, I am here You probably got it from my email address because the individual at the Society of Nuclear Medicine was out sick and was not able to send it.
Thank you. Agenda item number 5, application 17.33, request to establish a new level 2 HCPCS code to identify Ameluz. Primary speaker is Mr. Brian Rose.
I only see security alert. Oh, okay, it's coming up. Okay. Hello, my name is Brian Rose. I am the Director of Market Access for BioFrontera, and I am a BioFrontera employee. First, I'd like to thank you for allowing us to come to the meeting today. While we agree with the decision to establish a J-code for Ameluz, our concern is with the descriptor. Ameluz was approved by the FDA in May of 2016 and is indicated for the treatment of field treatment of actinic keratosis along with the rhodoled light. Excuse me. The way that the process is done in the physician's office is the lesions are prepared on the face and scalp. The healthcare practitioner then applies the gel to the field to get it to the proper thickness. And then they sit in the office while the drug incubates on their face for the time period, and then they sit in front of the rhodoled light for 10 minutes per field. Ameluz only comes in a 2-gram tube, and this is it's filled with air, but this is what the tube appears to look like. And in the descriptor, you remove the word gel. The package insert description of Ameluz is aminolevulinic acid 10% gel for topical use. And since it's approved for field therapy, the entire tube is used per treatment. One of the concerns we have, the recommendation was to bill per 1 milligram. And there are multiple descriptors of the drug Ameluz within the package insert. The first indication is for the 2-gram tube. So if we're trying to bill that per milligram, it would require 2,000 units. Obviously, that's not an option. The other two descriptions are 100 milligrams, that each gram of Ameluz contains 100 milligrams per gram of aminolevulinic acid, which is equivalent to 78 milligrams per gram of aminolevulinic acid. That ends up being very confusing in terms of how the provider would end up billing it. Also, the MACs right now, billing under J3490, each one of them requires the dosage be a 2-gram tube, as well as all the private payers who are reimbursing for this require the dose to be 2 grams. Now, when you build the other products on the market that have billed for, that are a combination therapy for actinic keratosis, the only one that's active is Levulon, and it's J7308, and it bills with 1 unit for the full 354 milligrams of ALA that's in the tube that's reconstituted. So the physicians are used to billing for 1 unit. The other drug that was available that was taken off the market was J7309, Metvixia. Their descriptor was 16.5% methyl aminolevulinic acid, 1 gram, and it comes in a 2-gram tube. So that was the J7309, which is still listed as active, but it's not on the market anymore. So, we worried that it would cause billing issues or also would cause the patients to be underdosed. If a physician thinks they don't need to use the entire tube, they might not use enough, and the patient won't get the full therapeutic effect. So our request is just to change the proposal from aminolevulinic acid hydrochloride 10% for topical administration 1 gram to aminolevulinic acid HCl 10% gel for topical administration 2 grams. And that's it. Are there any questions?
When I was reading the package insert, prescribing information, I did not see reference to that the 2 grams must be used. It referred to what thickness.
Yeah, and that's in section 2, but it states that, I can't remember the exact language now as I'm sitting here. It says, the initial dosing instructions state the 2-gram tube. And then if you go down to dosage form and strength is where it says each gram contains 100 milligrams, equivalent to 78 milligrams. And I can tell you the billing through the MACs when people have sent in 78 milligrams or 100 milligrams everything has been kicked back because they all want a 2-gram tube. as well as the fact that Metaspan, First Data Bank, and Redbook all have this listed as 2 grams and a price per gram. So if you look when it's the part where it mentions administration, how to administer the tube.
Method of administration?
Yeah, I believe so. I'm going from memory. It's a 35-page document with all the light instructions on it.
I see application of the gel, that the Ameluz should be applied to the lesion area or entire cancerized fields of about 20 centimeters squared. Using glove protected fingers or spatula, the gel should cover the lesions or entire fields and approximately 5 millimeters of the surrounding area with a film of about 1 millimeter thickness. Continues on. I don't see. Maybe I missed it.
Can I see what you're looking at? So this looks, can I show you mine? Because there's 2 different package inserts. This is the one that comes with the drug, and then there's a PDF one that was attached to your piece as well. And it mentions using the 2 gram tube. I have it on my computer.
Can you just send it to us? When you already have sent it to us?
It's part of the whole piece. There's one package insert that is the...
What's the FDA approved package insert?
That is this one. Comes in with the tube that I sent you. I'm sorry.
Can I see that?
Well, no, the other one is the printed one that comes out with the 35 pages where it lists the 2 gram. This is the one that you're reading from is this, and you are correct. But the thing about the combination therapy is there's 2 different package inserts. There's one that goes inside the actual box that goes to the office, which is the one that I submitted additionally. The one that was attached to the submission in the beginning, I spoke with Cindy, and it contains 21 pages on the operation of the light. So there's a little bit different wording in that than the one that goes inside the tube.
Okay, Cindy says we have the insert.
I'm sorry?
Cindy says we have the insert, so I'll take a look at that. Okay.
Well,
So
I was going to exceed the number of pages if I sent the whole insert. That's why I had to ask Cindy her permission.
Okay, so I just want to make sure I'm clear. Are there 2 different FDA-approved inserts?
No. There's that one, and then there's the one that we ship when we ship the light, because it gives all different instructions. And then in that part is where it mentions the 2 gram tube. So that might be where the confusion is. I mean, obviously, we'll make this work no matter how it goes if we do it by milligrams. The issue that comes in is the billing, and the questions that will come within the billing is how do we do this? And up to now, it's all been just bill 1 unit, and then the entire package has been that 1 unit.
Okay, because also what I was reading discussed storing an open tube, and I think it could be stored for 12 weeks or something like that.
I mean, that was in our European label. That was put in our U.S. FDA label. The other part of that is the drug that's on the market now is called Levulon Carastick. It's in a stick that you crush and reconstitute. The way that they do this procedure, and this happened within the MACs, and it was the CGS administrator, MAC, the medical director, who fortunately had already had the therapy done, so he understood it. What they'll do is they'll line up 4 or 5 people in a given day to do the procedure. If you reconstitute Levulon and you don't use it within 2 hours, it degrades and you can't use it anymore. And then you have a $350 piece of trash. If you accidentally open Ameluz, oops, just put it back in, put it away. And we had this discussion in the Palmetto. MAC has required that we put entire tube used. We submitted an official letter to all the contractor medical directors on our instructions, and any material that comes from the company will state to use the entire tube. It is not to be, in order to get the full therapeutic effect. And I can submit that to you by the end of the day today if you'd like.
Okay, thank you.
Anything else? Thank you.
Agenda item number 6, application 17.7, request to establish a new Level 2 HCPCS code to identify Kylena. There are no speakers for this item. Are there any questions or concerns? Agenda item number 7, application 17.9, request to establish a new HCPCS code to identify hydroxyprogesterone caproate injection. There are no speakers for this item. Are there any questions or comments? Agenda item number 8, application 17.13, request to establish a new level 2 HCPCS code to identify Cuvitru. There are no speakers for this item. Are there any questions or comments? Agenda item number 9, application number 17.14, request to establish a new level 2 HCPCS code to identify Zemplava. There are no speakers for this item. Are there any questions or comments? Agenda item number 10, application 17.23, request to establish a new level 2 HCPCS code to identify Tecentriq. There are no speakers for this item. Are there any questions or concerns? Agenda item number 11, application 17.47, request to establish a new level 2 HCPCS code to identify Lartruvo. There are no speakers for this item. Are there any questions or comments? Agenda item number 12, application 17.28, request to establish a new level 2 HCPCS code to identify Exondys 51. There are no speakers for this item. Are there any questions or comments? Agenda item number 13, application 17.43, request to revise existing code S1090. Primary speaker is Mrs. Bessie Gross. Bessie Gross.
Good morning. I'd like to thank the CMS HCPCS work group for the opportunity to present on agenda item 13, which is a request for a J-code for mometasone furoate sinus implant. I'm Betsy Gross. I'm the Vice President of Reimbursement and Health Economics for Intersect ENT and an employee for the company. The product that we're referring to, the brand name is Propel. Propel is a bioabsorbable, steroid-eluting sinus implant placed in the sinus cavities for the purpose of reducing inflammation. There are multiple peer-reviewed publications that demonstrate the clinical benefit of the product. The product is endorsed by relevant specialty societies. Payers support creation of a J-code for claims processing. And the reason for that is that there is not one single code that can be reported to all payers in all settings of care in which an implant might be placed. Therefore, we also believe that a J-code is consistent with the coding that exists for all other drug implants. So why is steroid delivery important in the sinus cavities? For background, there is a direct correlation between treating inflammation in the sinus cavities and the impact on the need for revision surgery. Chronic rhinosinusitis is a chronic disease associated with inflammation due to numerous factors, including postoperative trauma, comorbidity, and other factors that such as previous sinus surgery, that can create the milieu for complications. There are numerous ways to treat inflammation. One can be oral steroids. Unfortunately, oral steroids, especially in the Medicare population, can be associated with significant complications. A second way is the use of steroid sprays. Unfortunately, steroid sprays do not reach or penetrate the sinus mucosa. 60% is eliminated within the first hour after administration. Physicians have been creative and using steroid sprays and infusing them into sponges, in some cases into a cut-off finger from a latex surgical glove that they'll infuse with things and put that in the sinus cavity. But those have never been demonstrated to be effective in reducing inflammation in the postoperative period. Therefore, Intersect ENT embarked upon creation of a bioabsorbable alternative for patients that would treat inflammation. You can see on these curves that on the left, nasal steroid spray is removed very quickly in a matter of minutes when it's administered. By comparison, on the right, this drug elution curve shows a drug-eluting sinus implant and its solution of drug over days. In fact, a drug-eluting sinus implant can deliver steroids to the sinus cavity for as long as 3 to 4 months. There are numerous FDA-approved steroid-eluting sinus implants currently on the market. Since application to CMS in January, in fact, some new information we believe is relevant for CMS to consider. First, Propel, the original drug-eluting steroid implant, was FDA approved in 2011. It was approved for use in the ethmoid sinus. The ethmoid sinus is in the bridge of the nose. Data associated with the use of that product shows a 70% reduction in postoperative scarring and adhesions. Propel Mini, which is a smaller version of the implant, was FDA approved for use in the ethmoid sinus in 2012 and in the frontal sinus in 2016. The frontal sinus is in the forehead. Data associated with the use of that product in the frontal sinus shows a 54% reduction in postoperative occlusion and restenosis. When the frontal sinus restenoses or occludes, the patient typically goes back to the OR for another procedure. In February of this year, following our application to CMS, the FDA approved Propel Contour. Propel Contour was FDA approved for use in the frontal and in the maxillary sinus. The maxillary sinus is in the cheekbone. Data associated with the use of that product shows a 65% reduction in the need for postoperative intervention. All three of the Propel implants are all associated with a dose of 370 micrograms of imidazole furoate. The cost of the product is reported to Redbook per implant. And each of the three products has a distinct NDC code. In addition, in March of this year, a new drug application was submitted to FDA for a second-generation drug-eluting implant. This mometasone furoate sinus implant is being considered. We're awaiting a PDUFA date from FDA at this time, but has been submitted as an office-based alternative to sinus surgery. So the implant would be used instead of taking the patient to the OR. The data that has been published on this product shows a 3.6 time reduction in patients meeting the criteria for surgery. We wanted to make sure that the panel was aware of this new information since it evolved since the time the application was submitted. Currently, there is some coding guidance which is available for providers that states that due to the fact that the implant might be used in a variety of different procedures, the implant should always be reported separately with a HCPCS code. In fact, in this otolaryngology coding alert article, it states that a HCPCS code should be used. However, the selection of the HCPCS code varies based upon the payer and the setting of care. The reason for that is because the current code, S1090, which is specific to mometasone furoate sinus implant 370 micrograms, cannot be reported to Medicare in the office setting. Therefore, a J code would need to be used, J3490. There is a C code that can be reported to Medicare, but that C code can only be reported in the HOP setting, not in an ASC and not in a physician office. Another example of the variety of codes that exist within the office setting, that exist that apply to this product comes from Emblem Health. Emblem Health shows a list of various different HCPCS codes that apply to other drug implants, but the S1090 code, in the descriptor, it specifically states that the provider might also need to report a C code or the J3490. Currently, this has created some confusion among providers in terms of which code should they choose. As I mentioned earlier, an implant might be used in conjunction with a variety of different procedures based upon the fact that these implants are approved for use in the ethmoid sinus, the frontal sinus, and the maxillary sinus. Furthermore, a patient might receive an implant during a sinus surgery procedure that is performed in the office, or they might receive an implant in a procedure following surgery in the office to treat, for example, a complication. Some examples listed on this slide include a patient who might return to the office and they present with an adhesion, and the physician chooses to lyse the adhesion and then place an implant instead of taking the patient to the operating room. Another example might be a patient who presents during the postoperative period with recurrent polyposis, and the patient undergoes a polypectomy, an implant is placed, instead of taking the patient to the operating room for the same procedure. Another scenario might be a patient who undergoes a sinus balloon dilation procedure in the frontal sinus or the maxillary sinus, and then an implant is placed to maintain sinus patency. In these scenarios, the S1090 code can be reported to commercial payers, however, cannot be reported to Medicare. We believe there are numerous benefits to creation of a uniform billing code for Propel. It will ease administrative burden on providers and payers. It will expedite claims processing and facilitate resource tracking. It'll also ensure that there is consistent payment across the country, because right now providers and payers must negotiate payment, and payment varies considerably from payer to payer and state to state. It will also allow for a mechanism for outcomes reporting for payers to truly assess the value of the product in reducing complications in this patient population. We believe this provides a mechanism to report Propel to the Medicare patients to ensure access, and several payers have commented that they support the creation of a specific J-code. In addition, the American Academy of Otolaryngology Head and Neck Surgery has submitted comments to CMS, and unfortunately they were unable to attend this meeting. However, we understand that their comments have been submitted. We have those on record in paper if CMS would. It does not have a copy available. The American Rhinologic Society is also supportive of this application, and unfortunately, the representative from the ARS just left the OR and is en route right now, so he's not available, but will be arriving at some point and can share his comments. And the reason why both organizations support the creation of a C-code is because the cost of drug-eluting sinus implants is not included in the practice expense value of any of the CPT codes that I described on the previous slide. As mentioned, an implant could be used in a variety of different scenarios. Unfortunately, it would be inappropriate to include the cost of the implant in those procedures because the product is provided incident to a service, not as an integral part of that service. All of those CPT codes referenced on the previous slide can be performed without an implant, and in fact, more commonly are performed without an implant. Therefore, both societies feel it would lead to misvaluation to include the cost of the implant in the non-facility practice expense for any of those codes. Finally, the number of implants per procedure can vary. It's based upon individual patient demand, and while uncommon, some patients require only one implant. Some patients may require 3 because this is a chronic disease and there are multiple sinuses. Finally, we do believe that creation of a J-code for Propel is consistent with what has been established for other drug implants. This slide lists 6 examples, some of which specify dose, some specify per implant, but other existing drug implants that are used incident to a physician service in the physician office setting all currently have J-codes assigned to facilitate consistent reporting to all payers. In summary, we believe Propel has significant benefits for patients with chronic rhinosinusitis, and the use in the office setting is growing, and the indications continue to evolve. A uniform code that's reportable to all payers in all settings would reduce administrative burden and facilitate appropriate and consistent payment. We also believe this is important in terms of MIPS and quality reporting to track the value of new technology. Payers and specialty societies have expressed program need, and establishing a J-code for this product is consistent with what has been established for other drug implants. We therefore request CMS establish a J-code for mometasone furoate sinus implant. Thank you. I'll be happy to take questions.
I'd like to call Mr. Manish Wani.
Good morning. I'm Dr. Manish Wani. By of credentials, I am Vice President of Texas ENT Specialist and Chief of Surgery at Methodist West Houston Hospital. Financial disclosure, travel to attend meeting reimbursed by the applicant. So I'm a private practitioner in otolaryngology, and I do appreciate the opportunity to address the HCPCS workshop regarding the application for a J code for Propel, as you noted, a steroid-eluting sinus implant, which is used to reduce chronic inflammation in patients with chronic sinusitis. So by way of background, Texas ENT is one of the largest ENT practices in the United States. We have over 30 ENT physicians in 14 locations throughout South Texas. Our practice strives to furnish many ENT services in the office setting. Because it's easier for patients, it preserves hospital resources for patients who need a higher level of care, and is less costly for the healthcare system as a whole. I have extensive experience using the steroid-eluting sinus implants, for example, the Propel Mini, as well as the Propel Contour, in many of my patients with chronic sinus disease. Based on our feedback from our billing department, I respectfully disagree with CMS's preliminary assessment that S1090 adequately describes this product. Patients with recurrent chronic sinusitis, especially those with polyp disease, pose significant treatment challenges. It's a disabling condition, which is especially burdensome during high allergy season, especially at this time of the year. Since chronic sinusitis is an inflammatory condition, these patients often require multiple sinus procedures in their lifetime. Managing inflammation following a sinus surgery procedure is critical to reducing repeat operations due to complications arising from the inflammation. Using Propel to deliver the steroids directly to the sinus mucosa has resulted in dramatic improvements in these patients. The surgery can be performed in the office or in an office follow-up visit. Blue Cross Blue Shield of Texas is currently paying for the drug-eluting stent in the office setting, but we don't have a specific code we can use to bill Medicare because S codes cannot be used for Medicare patients. Using unlisted codes such as J3490 for Propel is a burden for our practice. Therefore, establishing a J code for Propel would allow our practice to submit claims to Medicare using the standard billing processes. Finally, Texas ENT Specialists recently became a member of the American Academy of Otolaryngology Head Neck Surgery's Regent program. This is a clinical data registry for MIPS quality reporting, measures development, quality improvement, and clinical research. Establishment of a uniform billing code for Propel creates a path for comprehensive reporting to capture cost and outcomes in these patients. Therefore, I urge CMS to reassess the need for a uniform code for Propel in light of the fact that the current codes cannot be reported to Medicare in the office setting. Thank you.
Dr. Jacqueline Corey.
Thank you. I'm Jacqueline Corey, MD. I'm a professor of surgery at the University of Chicago. I direct the ENT allergy program. I'm also a member of the American Radiologic Society. Thank you for the opportunity to address this work group. I'm here to provide additional perspective and information regarding the application for a J code for Propel, a steroid-eluting implant. Before I begin, I have no additional financial disclosures to report other than my travel expenses for the meeting, which has been paid by the company. I disagree with the preliminary determination that no new code is needed because the S1090 code does not adequately describe the product. The S1090 can be reported to private payers, and C2625 can be reported in the hospital outpatient setting. However, neither code can be reported to Medicare when I use a Propel implant in the office or in an ambulatory surgery center. Therefore, a new code is needed that will enable me to bill for this drug implant like other drug implants that can be used in this site of care. I'm board certified otolaryngologist. I have used these in my patients for many years. They're particularly valuable for patients with polyps, allergy, asthma, or other inflammatory conditions, and they can be inserted both in the office as well as in the operating room. My experience has been very favorable. I also am the otolaryngology CAC member for NGS, the Medicare Administrative Contractor for Illinois, although I am not speaking on their behalf. I am aware of the discussion that happened there for the Propel implant. Medicare patients are ideal candidates for Propel since they have a high rate of comorbidities and also recurrence, and because of this are not allowed to take oral steroids. Therefore, they're also, for the same reason, not good candidates for repeat surgery. Many of my patients have insurance through Blue Cross Blue Shield of Illinois, and Blue Cross Blue Shield in Illinois has instructed providers to report Propel separately from the procedure, which I think is correct. While I can report the S1090 code to Blue Cross Blue Shield of Illinois, this is not an option for Medicare and some other insurers. Establishing a uniform code that can be reported to all payers in all settings would simplify the billing process and also allow providers and research to better track utilization and to track outcomes. This could include valuable tracking for use in alternative payment models, especially those based on outcomes reporting. These implants are approved for the ethmoid, frontal, and maxillary sinuses, so they can be implanted in conjunction with numerous different procedures. However, none of these procedures includes the cost of the implant. In addition, the incorporation of these costs into the procedure is not practical because you don't put them in every procedure. In fact, less than 50% of the procedures do you add an implant. So you can't add that cost as part of the value of the practice expense, for example, for the procedure. And furthermore, the number of sinuses that can be done in one setting or the number of sinuses that might need an implant would vary from patient to patient. You could have 8 sinuses that need to be done, or you could have 1 or 2, etc. For these reasons, I urge CMS to reconsider the preliminary decision and establish a J code for Propel. Thank you for your reconsideration of the application.
Any questions?
I don't have any questions. I would just like to generally make a caution against taking coding guidance from anybody other than the insurer in whose jurisdiction a claim is being filed. So, you've submitted documentation saying that some organizations are saying it must be billed separately and you can use, miscellaneous code and whatever. That is not information that's provided by the payer that you're billing, and those are the people whose permission and guidance you need to code accurately when reporting to them.
That's a great point. Yes, the otolaryngology coding alert is just one example, but you're right. Other payers have also recommended separate reporting, but you're right, the otolaryngology coding alert is not as strong of a guidance to rely upon as the payer.
The reason that I mentioned it is because we had similar discussions at the CAC meeting in Illinois about this, and that's the only reason that I mentioned it.
Any other questions? Thank you very much.
Agenda item number 14, application 17.24, request to establish a new level 2 HCPCS code to identify Sustol. There are no speakers for this item. Are there any questions or comments? Okay, if you would please take the microphone. Thank you.
Hi, Dan Martin, Vice President, Heron Therapeutics, on behalf of the company. As a new company, just wanted to say thank you to the work group. Thank you very much to Judy for sort of guiding us through the process. That's really it. Thank you very much.
Last item of the day, agenda item number 15, application number 17.60, request to establish a new level 2 HCPCS code to identify Bavencio. There are no speakers for this item. Are there any questions or comments? Okay, at this time, our meeting is adjourned. We would like to thank you all for the excellent and thought-provoking discussions that you brought to us today. And we'd like to also thank you for taking time out of all your busy schedules to appear here today in person and to share with us your valuable input. We look forward to seeing you tomorrow or next year for those who won't be here for the duration of the meetings. Have a wonderful day.